Good afternoon. I'm your host, David Hiltz, and welcome to your March Citizen CPR Foundation Champions webinar. Today's program will focus on community defibrillation strategies, a timely discussion given the recent release of the ILCOR scientific statement on optimizing outcomes after out-of-hospital cardiac arrest with innovative approaches to public access defibrillation. Please mute your microphones, and as always, we encourage the use of the chat function to provide us with your feedback and questions during this webinar. We ask that participants be respectful at all times and refrain from sharing negative or degrading comments, as well as specific product promotions. The Citizen CPR Foundation is grateful for the generous funding from our partners, which support the production of this webinar and the mission of the Citizen CPR Foundation. There are three core values that form the basis for the Foundation's mission to save more lives through action at the community, professional, and citizen levels. First and foremost, we know emphatically the high therapeutic value of immediate CPR and rapid defibrillation. Second, we know that collaboration is key to improving survival from sudden cardiac arrest. And third, action based on best practices in science, education, and implementation is required to improve outcomes. I have a few important reminders for you all today before we get to our interviews. Please look for important information in your post-webinar email regarding an academic research study being conducted by researchers at Seton Hall and the University of Lynchburg regarding cardiac emergency preparedness in youth athletics. The study objective is to evaluate the level of preparation, training of personnel, and availability of AEDs for responding to emergencies in the setting of youth athletics. And the survey is directed at parents, coaches, administrators, and athletic trainers. Your help in distributing this survey in your own networks will be greatly appreciated. Additionally, we are delighted to inform you that the program team has developed a self-assessment and project progression tracking and score sheet that outlines the tactical elements and actions that, when implemented and combined, can improve outcomes from sudden cardiac arrest. Use of this tracking and score sheet will be helpful in performing a baseline assessment in your community, as well as serving as an essential tool in the iterative process of implementation and ongoing evaluation. To complement this, the program team has developed an implementation and resource guide entitled Challenging Sudden Death, a Community Approach. These will be shared with you all in the very near future. In an effort to identify interested parties and improve peer-to-peer collaboration and connectivity, please send an email to info@citizencprfoundation.org and simply share your name, what agency you represent, and the name of the community that is seeking to improve outcomes. We are exploring different methods for connecting you and other communities who are striving to improve outcomes. A reminder in this regard will be included in your post-webinar email. So now to the subject of this afternoon's program, rapid defibrillation strategies for the community. Despite widespread proliferation of AEDs, drop-to-shock times remain unacceptably high and bystander utilization rates remain unacceptably low. We will discuss barriers, science, innovations, and best practices in community-wide defibrillation strategies and tactics. AEDs are proven lifesavers, but only if they are used. We are joined live today by our great co-host, Ann Dahl. Ann is a true and celebrated champion of improved outcomes and hails from the Resuscitation Academy in Seattle. Joining Ann and I are Tegan Hampton, a program manager from the Resuscitation Academy, and Rich Shok, a member of the Heart Safe program team at the Citizen CPR Foundation. Of note, Tegan and Rich have successfully collaborated on the development of a revised community CPR toolkit recently produced by the Resuscitation Academy and the Citizen CPR Foundation. Additionally, they have been closely collaborating on the development of a soon-to-be published community defibrillation toolkit. These toolkits help in translating science and in the actual implementation of life-saving treatment recommendations. Welcome, Ann, Tegan, and Rich. And so, as we drop our visuals, we can get on to business. Ann, I'm going to hand the floor over to you. Welcome.
Thanks, David. And thank you for the personal leadership and dedication to keeping us all moving forward with these discussions. You know, every month you're on it, and I just big gold stars to you for everything you do to keep us all moving on this road together. So I'd like to just start out by summarizing the abstract for this important publication from ILCOR. Out of hospital cardiac arrest, as we all know, is a global public health issue that's experienced by 3.8 million people annually around the world. And as we know, only a very small percentage, 8 to 12 of those people survive to hospital discharge. We all know that early defibrillation of shockable rhythms is associated with improved survival, and access to defibrillators has been a significant challenge in tackling this problem. So until recently, public access defibrillation programs meant, you know, a static box on a wall that sometimes collected dust that few people knew about. But we know that programs around PAD do improve outcomes when they're used and when they're successful. But that percentage of cases is tiny. It's only 3%. So ILCOR, whose mission it is to improve out-of-hospital cardiac arrest, commissioned this statement with 3 goals in mind. Number 1, identify known barriers to PAD use and defibrillation. Number 2, discuss established and new strategies to address those barriers. And number 3, identify high priority knowledge gaps that deserve future research and attention. And so the document covers strategies to improve public outreach, understand and optimize human behavior around PAD use, explore AED technology and functionality, improve integration of public access defibrillators into existing emergency dispatch protocols, and then explore the novel AED delivery methods or vectors, which makes it sound even cooler and more high tech in my brain. So it included a writing group that refers to policy suggestions and knowledge gaps. For today's discussion, we're just going to focus on the policy suggestions and less on the knowledge gaps and research priorities, because I think this group on this call is keenly interested in implementation. Before we dive in, big hats off to Dr. Stephen Brooks and his team for this comprehensive and compelling piece of work. Unless we have guiding statements like this, I feel like we don't have a unified roadmap. So we're really shooting for the moon in this world that we want to create, where no one dies from sudden cardiac arrest. And so this helps us keep that goal in mind. Okay, so let's dive in. Tegan, let's start with you. So can you let us know what are some of the suggestions that ILCOR had regarding improving awareness and willingness to use AEDs?
Thanks, Anne. Can you hear me okay?
Yes.
Okay. So as we know, awareness of AED function and location is low. Even if people know how to use an AED, they don't necessarily know where it is. Less than half of people know how to use it or where it's located, and most prefer to wait for trained professionals to arrive to get that experienced help. So ILCOR discussed 6 ways for improving awareness and willingness to use AEDs. So I'm just going to touch on each of the 6 of those. So the first one that ILCOR mentions is this idea of behavior change theory. So they didn't delve too much into the psychology of this, but they talked about social marketing. So having audience change their behaviors for the benefit of an individual or a group or society, kind of using that as a motivating factor. And then they also talked about utilizing the behavior change wheel. The second thing that ILCOR mentioned was this idea of creating a culture of action and really using public messaging as the vehicle to promote that culture of action. So specifically, they mentioned educating the public on what out-of-hospital cardiac arrest is, because a lot of people don't know the difference between that and a heart attack. Teaching people how to identify it and how to respond to it, and then using popular campaigns such as hands-only CPR or call fast, call 911. Those are the 2 examples that ILCOR mentioned in the paper to promote that culture of action. ILCOR did point out that there's perhaps more research on the effectiveness of campaigns like that, which was a similar thread throughout, always promoting a culture of learning more and more research. Then the third thing that ILCOR brought up was this idea of global awareness days. So specifically World Restart a Heart Day, and then the idea of integrating AED use into where there's CPR promotion and training. And then ILCOR also mentioned this idea of engaging and empowering children, so building a generation of lifesavers. Specifically, they mentioned a couple of examples in Europe. The first one was Kids Save Lives, which was an initiative launched in 2014, where they promoted this idea of training kids for a total of 2 hours per year, beginning at age 12. And then the second one was a study in Denmark where they trained 35,000 children and then sent those kids home with CPR kits and encouraged them to train their loved ones. And that actually resulted in an additional 17,000 people receiving training. So this exponential growth in the power of that training. And then in the United States, as a lot of us probably know, over 35 states require some form of CPR training in schools. Someone just put in the chat multiplier effect. Yes, exactly. And then the other thing that ILCOR mentioned, the 5th topic that I want to just briefly touch on, is this idea of addressing psychological barriers and injury. So addressing the bystander effect when it comes to AED retrieval and use, especially when someone collapses in a group of people, and then addressing any potential psychological negative effects that volunteer first responders, bystanders, tristanders might experience. And then lastly, ILCOR talked about the importance of educating people about your local Good Samaritan laws or the equivalent, as those might vary state by state, country by country, making sure that people understand protections that they have. Oh, you're on mute.
I tried to stay on mute because we're on a busy, Tegan and I are actually in the same office. We're on a busy street, lots of sirens go by. And if people haven't delved into this document yet, I mean, Tegan's just given you kind of an insight. This is a really rich, fully packed document with so many suggestions. I know David will send a link out later, but there's some really compelling concepts that Tegan just threw out there for us to think about. And Pam put in the chat, talking about creating a normal culture around CPR, that it's just assumed that this is part of what you learn when you grow up. I also really liked this idea of trying to understand human behavior. I don't know if any of us around in EMS or and certainly in the United States, fire and EMS, have delved into understanding human behavior change to impact the outcomes that we want to see. So I loved that. I loved the idea of tri-standard mental health care. If we're going to create a world where no one dies from cardiac arrest, we've got to think and act in different ways that are outside our comfort zones. And so we just heard a lot of good examples of what that might look like. So Rich, tell us about the recommendations regarding optimization, reliability, and usability.
Yeah, absolutely. So the ILCOR document dove into the optimization of AD placements and the reliability of using them pretty in depth. The first part about kind of looking at optimization of placement is really important. And I think we're getting a lot of knowledge and insight. Back in San Diego during the Citizen CPR Foundation conference this past December, Chris Sun actually spoke on this very topic about the placement of defibrillators. And the historical kind of thing has been like everywhere where there's a crowd is where a defibrillator needs to be. And, you know, he really kind of presents some data that is really kind of opposite of that there's ways that you can take a look at where cardiac arrests have occurred in the past and predict where they're going to occur in the future. So he's used data from Copenhagen as well as a few other cities and compiled that onto a map and then used computer learning to come up with a predictive pattern on where cardiac arrests will occur next. And then the strategic placement of devices actually reduces the total number of devices that are out there, which allows for more coverage area on the map. The ILCOR study looked at Copenhagen again, and they found that when AEDs were directly adjacent to where the cardiac arrest was occurring, that they were used about 36% of the time. However, when they existed more than 200 meters away from where the cardiac arrest happened, it was only retrieved about 14% of the time. And that's in a location that does a really good job with their cardiac arrest survival rates and, you know, keeping up with the data and coming up with actionable solutions for it. So I think we need to learn a lot about how we can best optimize placement of devices. Part of this optimization includes allowing for devices to be accessed at all times of the day. In the United States, we know that many of our devices, most of our devices that go to say, are locked up after 5 o'clock p.m. They're in the nurse's office. They're in a locked cabinet. They're in the conference room in a locked building. They're not accessible. So moving these devices to outdoor locations where people in the community can access them 24 hours a day, 7 days a week when they're needed really is going to help with improvement of optimization of AED distribution. The other part here is about the reliability of a defibrillator and how that kind of works. Technology has advanced. We typically only see the same 7 or 8 AED manufacturers that are out there, and they're using the same devices. Every so often, a new device gets released and gets FDA cleared, but you know, there seems to be some stagnant technology here that really can be improved upon. Things that can look through artifact and identify when a shockable rhythm exists. I always flash back to the first cardiac arrest I worked when I was a volunteer firefighter, and carrying the patient down the stairs with our Zoll defibrillator on, you know, the backboard. And halfway down the stairs, we had enough artifact going on that the Zoll said, "Hey, it's time to shock." And we had to make that quick decision: do we go up the stairs or downstairs, and what do we do next? So, you know, really kind of identifying ways that we can improve the detection of shockable rhythms so that we're able to, you know, provide better care for the patient.
I'm really fascinated by a couple components of this section and the points that you brought up. You know, first and foremost, if anyone knows about the Resuscitation Academy, which is where Tegan and I work, we have one true mantra. It's like our golden rule, and that's measure and improve. And just keep measuring and improving, measure and improve everything you do. If it's worth your effort, if it's worth the hard work and the resources investments, then it's worth always measuring. So collecting that data and looking studying a heat map, for the high incidence of cardiac arrest is a much more surgical approach to AED placement than just going, as you say, going where the crowds are. So that gets back for me to measure and improve. And then, the question about the 24-hour access to PADs, it strikes me that there's so many elements beyond, that are part of this landscape. So there's having it, an AED have access for 24 hours. But then people have to know where it is. There has to be signage. There's got to be training and reminding that wraps around, each of these good ideas, and then they're all interconnected. I responded to a pulse point cardiac arrest and it said the AED is, in the building. Well, I ran in the building knowing that time is of the essence. And the security guard said, the what? The AED, the external, the Shocky. And then it was like, I'm just going to go because I could hear EMS coming. But each of these pieces needs so much wrapped around it, and even more important for us all to work together. So Tegan, so ILCOR made some interesting recommendations regarding AED signage. Can you give us an overview of sign-related policy suggestions?
Yeah, thanks, Anne. So Anne mentioned our one golden mantra, which is measure and improve. And another one that we have somewhere on the wall behind me is, if you've seen one EMS system, you've seen one EMS system. And what we learned from this paper is that actually is also true of AEDs. So if you've seen one way a community approaches AED placement and signage, you've seen one way a community approaches AED placement and signage. So it really is variable and depends on where you live. So ILCOR has been working on a universally understood and recognized sign for an AED. Further research is needed on whether one universal sign is better than another, kind of what the gold standard would be. But they do promote this idea, and I agree that we should have a universal sign, right? Something that is understood no matter where you are, something that is used in the same consistent, successful way, no matter where you are, to identify an AED. Specifically, so as of 2020, they said that 2/3 of AEDs have no signage, which in our pre-huddle right before this meeting, David Hilt said that, during the course of this call, 20 to 30 lives will perish because of out-of-hospital cardiac arrest. And if you think like, wow, some of those lives might have had an AED nearby that no one knew to get, no one knew to go retrieve because there was no signage in front of the AED or pointing to the AED from nearby. So this is a tragedy that we really need to fix. So specifically, ILCOR recommends signs within 200 meters of the AED, signs that are viewable from 50 meters away, and signs that are illuminated, lighted, and the cabinets holding the AEDs are illuminated as well. I went to a children's museum this past weekend with my son, and I tried to find the AED. I challenged my husband, who can find the AED first, and we didn't find it till right before we left. It was tucked away in a little corner with no sign. And there were quite a few people at this museum. It was quite large, and no one would have known where that AED was. So this is something that we can and should need to fix.
Absolutely. David said in the chat, seems simple, right?
Yeah.
And yeah, David, you want to comment on that?
Sometimes, there's lots to do from a technology perspective, but we have the resources today to make a difference. And sometimes doing some simple things really well can make a very significant difference, right? And I think the signage is a prime example. Well, ILCOR is, market testing certain images and things to see how it resonates with people around the globe. We can help people now by, utilizing signage, and then where is it? Like directional signs. And I've seen some advocate implementers, I think one of them might even be on the call, where they have, placed signage on the roadside directing people to nearby AEDs. So, these ideas, we don't need to wait for another ILCOR statement or another scientific paper. This is something we can do now. It only requires an off-the-shelf sign, 4 screws and a screwdriver, right? This is can do. So I'm mindful of the time and I'll be quiet.
Thank you. Thank you. I know I want to comment too, but I won't. I'm going to move on. So Rich, let's turn to and talk about mobile device apps and crowdsourcing. So where does that fit in all of this?
Yeah, so that's a really neat and really new concept. There's been a couple mobile crowdsourcing devices or apps that have been available over the past, 6-7 years. And they've really gotten their start on, identifying ways that they can get AEDs and CPR delivered to the patient's side much faster than waiting for EMS to arrive. One of the real true things about EMS is that by the time we're on scene, if CPR has not been initiated, if a defibrillator has not been used, we don't really have a viable patient that we can do much with. So we're really dependent upon getting people starting to do CPR immediately, whether that be directed by the dispatcher when they call 911, or whether that be directed by an app that says, hey, a cardiac arrest is occurring nearby and you've signed up for the app and you know what to do and you're trained, so go respond. We know of PulsePoint, for example, in the United States, and Good Sam, and there's a few others that are out there that provide a signal to responders that are in the immediate area of the cardiac arrest to let them know what's going on. There's also been a couple technology improvements here that have said, okay, well, we have this existing on mobile devices, but that doesn't really help much when it comes to actually delivering an AED unless there's one that is also nearby. So citizen responder AEDs have also come into play here, where a defibrillator is outfitted to the responder, and they have that similar app with maybe a larger radius that they can respond to, and they'll deliver the AED to the scene. There's also been some technology that is coming out that looks at having AEDs that are triggered with their own crowdsourced, application or notification to let you know that, hey, there's a cardiac arrest in your neighborhood. Grab this AED and respond to it. So we're seeing quite a few things, but the whole goal here is to get the AED to the patient's side much faster than EMS can arrive. And we have an average 6 to 10 minute window for EMS responders to get on scene with the first AED. So there's plenty of time that we can really be working within that 1 to 6 minute range, to get something on scene.
Yeah, this is the future. This is the future, and there are communities in Europe and in Asia that are leading the way. So if you don't know about the Heart Runner project in Denmark, you should definitely check that out. And then stateside, there's a project out of King County EMS that includes cities across the country called Verified First Responder. So you can contact myself or Tegan, and we can get you in touch with sending in off-duty medical providers into private homes. Again, I could pause here and we could talk for a while on that, but let's keep going because I want to be able to summarize the whole document for you all before we wrap up. Tegan, I know that they've said things about novel or strategic delivery for AEDs. Can you tell us what the document says about that topic?
The document covers 4 main things related to novel and strategic delivery vectors for AEDs. So I will briefly touch on each of those 4. The first one that they talk about is dispatcher-assisted AED locating and coaching, so similar to dispatcher-assisted CPR. This idea that if there's a registry of AEDs and where they're located that dispatch has access to, they can tell the caller, hey, there's an AED down the hall, have someone go get it while you continue CPR. And ILCOR points out that this is great in theory, and there's a lot of rich, wonderful potential for it. It is quite complex when you get down to it to coach a bystander through locating and retrieving the nearest AED, especially when you're trying to prioritize providing CPR. So I think we mentioned earlier, it's not difficult, or it's not And what's the saying? It's not complicated, but it's not easy.
Exactly.
Yeah, another one of our mantras up here, we're covering them all. So there's potential for AI and machine learning to maybe help with this in the future. We just need to figure out the best way to optimize it. And then the second thing that the document mentions is using police and firefighters if you're in a non-fire-based EMS system. So the idea of equipping roaming police officers with AEDs, because in some cases they may arrive sooner on scene than EMS, and then be able to defibrillate a patient before EMS even arrives. And we've seen success with this in King County and in other systems around the country. So we'd be happy to connect you with some groups that are doing fantastic work around this. The third thing that the paper mentions is community responder programs. So both laypersons and off-duty healthcare professionals kind of utilizing both cohorts of people, dispatching these volunteers in an area with longer response times. More research is needed, although the paper does mention a community in Scotland that is seeing quite a bit of success with that program. And then lastly, this idea of using robots as novel delivery vectors for AEDs. So there is great potential to reduce time to defibrillation through robots or drones. And how this would work would be dispatching AEDs via the robots or drones simultaneous to when you dispatch EMS. And we need to overcome some logistical and regulatory challenges, I think, before this is more widespread. We are seeing a few examples where this has really worked. There was one news story recently, I think in Denmark, where this resulted in a saved life, which is wonderful, but we need to do some more work before we can spread that more widely.
This topic and the crowdsourcing, this is the future from the world of Andal's perspective, but it's the awkward adolescent period that we're in, right? There's growing pains. It just feels like it's a little clunky, that we don't quite know what we're doing, that we might be taking some risks that we shouldn't be taking, but we're going to move through it, and I think we just need to keep at it and exploring those horizons. So let's shift gears now. I want to just touch on in the document, they call out knowledge gaps and research priorities. And I said that we weren't going to focus on that very much, but I just want to give everybody just a little bite-size kind of summary of what those are, so you know what's out there in that document. And so Tegan and Rich, we're just going to go through these rapid fire. We'll start with you, Tegan. What does the document say about early detection?
Early detection, so helping bystanders understand what to look for and what to do is essential in identifying a cardiac arrest and intervening early enough to slow the slope of death. Early intervention couldn't be more key.
Great. Rich, public awareness.
Public awareness, starting early, getting kids to recognize what an AED is, getting them to learn how to do CPR, or even recognize when to get an adult involved. It's really important to get them started as soon as possible so that they can have the familiarity throughout their life, to be able to act in an emergency.
True. Tegan, optimizing.
I think if you want to optimize cardiac arrest survival in your community, training on early defibrillation and identifying a cardiac arrest, widespread and accessible AEDs, and proper signage are all essential to optimizing survival in your community.
Great. Rich, AED registries.
AED registries, that's a rough one. There's so many registries that are out there, and the registry is only as good as the one that the dispatcher will reference in the time of crisis. So coming up with a universal registry that all systems are going to use, that is referenced automatically by the 911 dispatcher and can get the AED in the person's hand when they call 911 right away.
Yes. Tegan, signage.
An AED is about as useful as a bookend if no one knows where it is or how to use it. Signage is an easy fix.
Easy, not easy. Rich, mobile apps.
Mobile apps, once again, we're using technology here. We're going to learn more and more from it. So, convincing the people that are in your community that have the stakeholders and the stakeholders and ones responsible for cardiac arrest management in your community, getting them to know about the mobile apps that are out there and to find ways to integrate them into your community, getting people to download them, going around saying, hey, do you have this app? Do you have this app? You should really download it.
Absolutely. And last one, Tegan, personal and home access.
So several companies are developing miniature portable defibrillators for your home that are around the same cost as a high quality smoke detector. More research is needed, and however, it's a really exciting opportunity to think about the idea that you could have a life-saving tool in your kitchen.
Super exciting. Yeah, all of these are describing really for me like, oh, wouldn't that be great if we had all of those things? And Janet Trethway said very wisely that all of this is hard work. It's hard work, but it's noble work. It's the work we should be doing. Thanks for that rapid fire. I love that you kind of condensed the material for us. And we're kind of going to start to head towards a different part of the webinar. But before we head over to doing some Q&A, David can step back in to join the conversation. Tegan and Rich, I know you've been working hard on the community defibrillation toolkit. Can you talk just a little bit about what's in it and any highlights for this group?
Yeah, so the RA has a series of toolkits on our website, resuscitationacademy.org, and we're slowly going through and updating all of them. They're all free to download, free to view, free to use. We're working with the Citizen CPR Foundation to update the rapid defibrillation toolkit. And our goal with this toolkit is really to make it an A to Z guide for how to start and maintain a strong AED program in your community. So it covers things like AED maintenance, registries, including what they are, how to start them, how to use them, examples of them, training recommendations, this idea of AED oversight, things like that. Rich, do you have anything you'd like to add?
No, it's just been a really great experience working with Tegan and Dave on both of the workbooks that we've been developing, and really looking forward to having that out as a toolkit for the community to be able to use as a guide for ideas in implementing their best AED strategies.
Yeah, as Rich mentioned, we recently released the first one that the RA and Citizen CPR Foundation worked together on, which was the Community CPR Toolkit. And then this is the follow-up to that, the Rapid Defibrillation Toolkit is, and we hope to release it in the next month or two. So stay tuned for that.
It would have been out sooner if it weren't for ILCOR, right? But in all, pardon the interruption, but the content and information in the ILCOR scientific statement is of such high value. It would be really foolish of us not to integrate that knowledge and content into the toolkit. And an ambitious timeline, given the 26 pages of kind of new stuff that, ILCOR was generously sharing with all of us. So, I have to say, I looked at the agenda for today's call and I said, boy, this is pretty ambitious. But, we have our guests for a reason, and Anne, masterful job, and serving as co-host, right? And Tegan and Rich, I mean, talk about bold, brief, to the point. Well done. So now we're going to entertain some questions. Now, Brian Haskins from Australia asks a question. Doesn't matter what type or color of the AED sign that we use. Brace yourselves, panel, because all of them are in use in Australia. And I don't think they have the market cornered on sign confusion. So what say you? Jump right in.
So fun fact, before I started off in my world in EMS, I worked as a graphic designer.
Oh.
And oh my goodness, I mean, I think everyone on this call probably has experience with, okay, we're gonna make this thing and we wanna put 2 logos on it or 1 logo on it. And you would think that, or even if can we decide on 1 logo, that it turns into a big issue. But Brian, I would say I would like to look to some of the international efforts to create universal signage, say around the hospital signs, you know, the blue and white H hospital signs. I hope that's not different in Australia. But that type of work, I think we should look to lessons learned.
I think the most important thing would be consistency. So whatever we decide, something that's eye-catching and consistent, so that when you see it out of the corner of your eye when you're on vacation somewhere else other than where you live, it's immediate. You still have that that recognition and that association with what it is.
Rich, would you like to contribute?
I mean, that's the only way that we're going to get universal recognition is by having the same exact sign used everywhere in the world, maybe even on the moon someday.
Yeah, right. And so, Brian, what a great question, because, you know, while we've all kind of shared our perspective, we don't have an answer, right? You know, it'd be easy to pick on any of the signage that's out there. You know, I'd love to put it in front of some, you know, members of the public and ask them, what does this mean to you? You know, ooh, don't touch, I could get shocked, right? High voltage. I mean, you know, lightning bolt over the heart, red heart, white heart, green background, white background, red background. You know, I think we need to work towards developing a universal symbol. Use the symbol that seems to be prevalent in your location, but dear Lord, I think we should probably avoid developing, hey, I'm going to develop a new AED sign logo. That's probably not in our collective best interest right now. But yet we're all very passionate about what we do. And so this is almost a natural tendency, right? And so we come full circle back to a simple sign. Could we just do what would be the impact of a well-developed and utilized sign, right? And knowing that all of these things roll up into a reduction in time from collapse to first shock, and hopefully, you know, neurologically intact survival from cardiac arrest. I'd also make mention that, you know, I listened to a great podcast, I think that's what you call it, I'm showing my age, that 2 of the docs did, Kurz and Stevens. And they talked about AEDs not just being defibrillators, but CPR assist devices, which I thought was pretty intriguing as well. So let's see if we have any other questions. Let's see. Location of signage with arrows pointing towards the AED. Yes, the idea of directional signage makes a great deal of sense, but I will tell you, having dealt with signs, specifically heart-safe community signs, that some municipalities have very strict rules and regulations around what types of signs can be placed on the roadside. If it's a state highway, you can't just put up a sign willy-nilly. You know, there are regulations around that. But, you know, if we apply that to a building, other things of that nature, it makes complete and total sense. Let's see what else we have here. Paul Lank talks about community responder programs. I think this has a great deal of life-saving potential. And so we appreciate that. Let me just scan here.
David, Dr. Cohen has a question. Any data on AEDs being stolen from outside 24-hour locations in the United States? Big cities like Asia and Scandinavia countries might be very different from the USA.
Oh, so a really interesting question for which I'm very thankful. ILCOR is a scientific body, and so they looked at published data regarding theft and vandalism of AEDs. And they looked at two studies specifically, and basically came to the conclusion that it's not an issue. And quite frankly, if you look at the millions of AEDs that are out there, and the ones that are either tampered with, stolen, whatever, it becomes a very, very small number. However, the media, I know this is going to come as a shock to you all, pun intended, but the media has a tremendous influence on public behavior. Sometimes not the behaviors that we want, regretfully, right? But if you look anecdotally, in the news, theft does occur, vandalism does occur, again, in a very, 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 very minute number of cases where AEDs exist. However, when the general public sees these in their newspaper, they go, oh, it's such a big issue. And that, in my opinion, and this is my opinion, not supported by science or by the Citizen CPR Foundation or my employer, that represents a barrier to the expansion of 24/7 accessible defibrillators. So, excellent question. Published data, no issue. But then some of the anecdotes would say that they do occur, and it may, I cannot say, it may have an influence on the public's willingness to put them out with, open access. Something that we need to really sort out. I hope that adequately answered the doctor's question, at least for now. It's interesting. Somebody here, again, anecdote, not evidence. Sorry, it's just hearsay. My aunt's cousin's sister's brother's husband. But we have somebody here that the school district that I am helping has had 4 AEDs stolen within the last 3 months.
But then Brian said that they have theirs on their university campuses and no one tampers.
And no issue there.
Yeah.
Right? Yeah. And again, perception is everything, right? And as much as that, if we look at kind of a similar situation where like the media puts a picture in the newspaper about life-saving AEDs and shows a doctor with the manual paddles on the chest, is that helping, right? Or is that reinforcing the notion that, whoa, that's not for me, that's for a doctor, right? So I think we need to be very cautious about some of these things. And again, I look at, we have so much to discover, so much to learn, so many lives to save, right? And we need to use evidence and science to direct us, but we should be aware at the same time of what other unevaluated influences are going on that may be barriers to our overall success.
Hey, David, Janet Trethway had a question further up in the chat that you might not see. Her question is, do you have suggestions for a maintenance campaign similar to change your smoke detector battery during daylight savings time?
There's a nice write-up that Tegan and Rich have done in the toolkit about AED maintenance. I think if we look at smart technology, and by the way, smart defibrillators, when I first got in the business, were ones that would tell you if you have a high probability of successful termination of VF if you shock now versus wait, do something else, wave a magic wand before you do that. In any event, I think that technology can help us here. I mean, like an automatic notification within a device that I'm not well. notifying the true central authority, right? For now, right, today, it's like, it's a responsibility, right? It's just as much a responsibility of maintaining fire extinguishers in the state of readiness. It's the same kind of thing. I think campaigns around, change your clocks, check your smoke detectors, check your defibrillator makes a great deal of sense. But I also think that this whole movement of moving AEDs outdoors, not only do many of those solutions come equipped with, an alerting smart feature, but it also enables the general public to say, oh, why is there a beeping sound coming from that box? I wonder if there's something wrong. I should notify somebody. So, I think, Janet, great suggestion. I think collectively, if we all got around, change the clocks, check your defibrillator, check your smoke detectors, that would be great. I know that personally, I've been doing that for years, probably hasn't had much of an impact, but if we were to do it collectively, we might identify some of those defibrillators that are not in a state of readiness, which I think, according to most recent statistics, is upwards of 20%.
I agree, and I think it has to be part of the equation and part of the discussion, especially as we talk about the promotion of ideas like an AED registry, this concept of integrating it with a PSAP so that dispatchers can potentially in the future send people to retrieve an AED. If they send someone to get an AED that doesn't have pads or that has an expired battery or a dead battery, that's, not great, to say the least. So it has to be part of the equation.
Yeah, I see Tom Ray talked about law enforcement defibrillation. That has a very special place in the RA Citizen CPR Foundation toolkit. Although, if you look at the ILCOR statement, it didn't get a real fabulous glowing, wow, this is where you invest all of your efforts, right? But at the same time, we have to use common sense, right? And I'll go back to, if we can reduce time to first shock by whatever means, whether it's, flying by drone or delivered by a police officer, by a first responder who's, equipped with a defibrillator, whatever we can do, right? Minutes matter, seconds count. And we have the ability to shave time off time to CPR, shave time off time to, first shock, right? That first shock success, so important, whatever we can do. It's all time. And there are so many different strategies. And I will get ahead of myself and kind of spill some of my closing comments now. It's like, any community is going to have to look at a variety of different strategies in order to get this done. It's not going to be the magic bullet. That magic bullet, the secret sauce, we just keep looking. It's going to take a variety of different tactics to really achieve success here. It's, can't put them on every telephone pole, but there's a lot that we can do now to develop a culture of action. All right, so I'm looking at the time. So I'm going to pull a few slides up and I'm going to wrap up today's discussion. And it looks like everyone stayed for the entire webinar. So kudos to Ann, Tegan, and Rich. And I should darken my screen. So here we go. All right. Let's see if we can get the gods of technology to embrace us once again. There we go. Oh, too much. There we go. One of my favorite photos, right? And the spirit of, local situations deserve local solutions, right? So Ann, Tegan, and Rich, again, thank you so much for generously facilitating this conversation. Improving time to defibrillation is an essential strategy in improving outcomes from sudden cardiac arrest. Our discussion has highlighted the importance of continued efforts. It is clear that a culture of action is needed and that a variety of tactics are needed in order to fully leverage the life-saving potential of these devices. Additionally, local circumstances and factors necessitate the need for localized approaches to improve drop to shock intervals. Regardless of what tactics are used, we are mindful that any and all efforts to reduce time to first shock are valuable, and we must continue efforts to inform and empower citizens to act not as bystanders, but as tristanders. And as implementers, that's us, that's me, that's you. This is our responsibility, okay? Now, mark your calendars and please join me and my co-host, Dr. Justin Semstrott, next month for a focused discussion on the prevention and treatment of drowning. Justin and I will have some interesting guests joining us for this, yet another timely discussion just in front of the warmer months here in the States. And as we approach the end of today's program, your feedback matters. So, please communicate with me directly if you like. Let me know, how are these going? Are they helpful? What ideas do you have for shows in the future? And this brings us to the conclusion of our Champions webcast for this month. As always, and on behalf of the Citizen CPR Foundation, and in this case, the Resuscitation Academy, thank you for your time and for all that you do every day to improve outcomes. I am David Hiltz, signing off, and good night.
Thanks, David. That's great.